Hello, everybody, and welcome to Recovery Machine. I'm your co-host, Nathan, joined as usual by co-host Corey, somewhere on your screen here. And this is our... Hello, buddy. How are you doing?
I'm good. I think you were about to say happy anniversary.
That's right, yeah. We've made it a year, so very impressive, and we're very thankful for the people who have supported us and have been listening and watching. Really encouraging, and it's been fun.
It has
been a lot of fun, actually, so I'm glad we get to keep going.
Yep.
And because this is a special episode, we've brought in a special guest. Welcome to the podcast, Dr. Mandy Manak of the ICDO. How are you doing?
Good, Nathan. It's nice to see you guys and nice to meet Corey finally.
Yes, likewise. Thanks for joining us today.
Yeah.
Thanks for having me.
I know you're very
for the
busy.
Invite for a long time.
Exactly. We did post an audio clip that gives people kind of a background into your education credentials, experience, etc. Just because there's quite a bit there to explain, and I didn't want to, waste your time.
For people, yes.
Making you go over every letter behind your name, but. So I did that. That's posted, and if anyone hasn't listened to that yet, I encourage them to. You'll be able to find it on our normal platform there.
Yeah.
And I guess there was a part there that I didn't know about you being specialized in being able to discern between chronic pain and addiction, which is interesting. We might talk about that more, I think, at another time. For now, we're going to talk about more along the lines of things that we've discussed previously in the show. So to start, we haven't talked for a while. I've known you for a few years, but you are very busy. So what have you been up to lately?
Oh, lately. Well, I don't know what you have on that little bio, but I'm the medical director of a clinic called the Interior Chemical Dependency Office in Kamloops. Mm-hmm. That is an outpatient clinic where a lot of the stuff is on opioid agonist therapy. But myself, I also aggressively treat alcohol use disorder because it's much more common than opiate use disorder, as well as doing benzotapers and getting pain patients off of their narcotic medication, cannabis use disorder. I'm also the medical director of Interior Medical Monitoring, which, as you know, is a medical monitoring company here in Kamloops, one of two. And more recently, I have become the co-chair of the Physicians Health Program Steering Committee with the Doctors of BC, so that kind of keeps me a little bit busy. And in addition to that, last year I opened up a 10-bed youth treatment center for youth age 13 to 18. And this year, within a couple of weeks, we're waiting for licensing to happen. We've got a 20-bed inpatient treatment for adults starting. So I've been trying to keep out of trouble, but I don't know, it's not working very well.
Yeah, you like to be busy. That's amazing.
I don't know if I like it, but it just happens that way.
It just seems to happen. Yeah. I did look into that, opening one of those before when I was up at Chetwynd, and it's quite an undertaking.
Yeah.
So did you have some help with that as far as, is there like a partnership involved, or are you?
Yep. Yeah. So, most doctors aren't very good at like the business side of things because they don't have time and they have to do it off their desk. So I have a business partner. His name is Daryl Smeaton. He belongs to a company called Active Care, which they provide housing for troubled youth through the Ministry of Children and Family. So they have about 200 staff in the province. They have about 35 homes in 6 different cities. So they're quite robust in terms of the facility kind of, HR and business side of things. So I've partnered with Active Care. It's a 50-50 partnership where I do all the clinical stuff, come up with all of the policies and, the programming for the inpatient kind of stuff. And we've got an executive director that we've hired from Alberta. We've got 2 master's level counselors, a master's level social worker, 24-hour nursing care. So it's actually quite robust. Mm-hmm. And this came about because Interior Health put out a request for proposal last year for the youth and this year for for adults. And so this will be a fully funded for the patient facility, no extra cost. And yeah, I think that'll help reduce one of the barriers that's been present for many years, especially in Kamloops, because we don't have anything here for funded beds.
Yeah, that's just one of the problems that we're facing in BC. But yeah, that's
Yep.
lots of people out there looking for, who want help and can't get it fast enough. So
And
kudos.
we talk about a two-tiered healthcare system, and there's no place like addiction medicine where that two-tier is more obvious because some people can afford to be healthy and some people can't, right?
Mhm.
Yeah, you could almost say it's three-tiered when you get
Yep.
into the upper echelon there.
Yep. Yep.
So, one of your jobs at the ICDO involves diagnosing and recommending treatment plans for healthcare professionals like me and Corey. We both went through a procedure where we've talked about the independent medical evaluation before.
Mhm.
Some people, when they get into trouble with drugs or alcohol, go through a few of these. Some people go through one. It depends on the situation. Um, I got it. I mean, there's many questions that I could ask you about that, but I think to keep it, relatively, relatively non-complex as far as getting into all sorts of different, whys and hows. I see a lot of because of my business with Obsidian. I'm frequently asked now to kind of look at people's IMEs and assess them, and I have no educational background to do so. It's just my experience over the years and seeing so many of them. I kind of get a feel for which doctor does what, and one of the things I see on there that seems to be one of the more frequent things that is requested, or I guess suggested as treatment, is inpatient treatment, and it's usually in a 35 to 42-day range. And I was just wondering why that is consistent, why that number of days in treatment.
Fair enough. So just a point of clarification, ICDO, which is the Interior Chemical Dependency Office, is a publicly funded, so through MSP for regular patients. It's the interior medical monitoring where the IMEs are done and the medical monitoring is done. That is where I see the safety sensitive individuals. So different systems, because one is private pay, because anything that is billed to MSP should be medically necessary, and IMEs are by definition a requirement for people's jobs, so not covered by MSP. Unfortunately, that's why some of these cost and hoop jumping come into play. So just to clarify the two different paths that people might take. So when somebody's having an IME done in the old system where we used to have the DSM-4, which was, you meet criteria for substance abuse, it generally meant that the illness wasn't bad enough that maybe you could try outpatient treatment. And it didn't really happen a lot, to be honest, because by the time substance use affects the workplace, it's considered generally late stage in the illness. So, if people, hadn't come through their work path, they might meet the criteria for abuse. And that might mean you could get outpatient treatment. Maybe you have some PTSD that needs looking after. But if in the DSM-4 you met the criteria for dependence, it automatically meant that you had inpatient treatment. Partly because by the time things enter the workplace, meaning, absenteeism, lateism, work performance is generally considered quite an advanced stage of the illness. So all of these rules are, they come out of the the Federation of State Physicians Health Program in the US. We actually don't have great guidelines in Canada. So all of these recommendations generally come out of the US, which, their problems are a little bit unique. They have more services available, and they're physicians' health programs are run a little bit differently than they are here. So most of the inpatient treatment is usually 28 to 42 days. And part of that is just a balance between, being off work, cost. And in our case, as you kind of maybe gonna allude to, because I saw that in one of your summary questions, why are they sent to Ontario? So in Canada, if you are a healthcare professional, you generally require to be in a healthcare professional stream. And that's simply because of the nature of our jobs, we have access to medication. And, to be honest, we think we're smarter than most people. And so we have ways to kind of, go around rules and stuff about access to medication and knowing what kind of symptoms we shouldn't be showing. So because of our unique situation and access to medication, healthcare professionals need a healthcare professional stream, and in Canada, there's only two. There's Homewood and Bellwood. Both of those programs have ranged anywhere from 28 to 42 days. Part of the range in that is one, dependent on the program, because I think it was Bellwood that used to be 28, now it's 42. But in addition to that, the Ministry of Health will actually pay for people to go there. They don't do that with anyone else. And that's simply because in BC, we do not have a healthcare professional stream. It's not to say that healthcare professionals don't get into like non-healthcare professional streams, but that is really what should happen.
Okay. And I think we've discussed this before off the record, but this healthcare stream that you're referring to, I don't know what that is, because the only difference I see in the facilities over east is that they have a caduceus group, and it's very loosely run. There's a bigger one, and then there's a weekly one that they take healthcare professionals out of the population, which is, you're put amongst, it's not like you're segregated into a population of healthcare professionals. You're put with everybody. It doesn't matter. It could be a person right off the street who's detoxing. Not that, it doesn't matter to me personally, but it's not a specific facility meant for healthcare professionals. Right. Also, it would be very easy to set up the same thing in BC. So it's confusing, right? Because when I look at how much money it costs, and this is something that the taxpayer is paying for, to send me to Guelph costs roughly $40,000 because I'm from BC, even though it's a $12,000 program. So it makes me wonder, why can't I just attend a normal treatment program and attend a caduceus meeting, and there's no difference. In fact, to be honest, the facilities I've seen in BC, well, almost every facility I've seen is superior to Homewood. Bellwood does have some good features, but Homewood, I just wonder, is it the government that hasn't investigated to see what really is being offered, or what's going on here?
You know what? I think it's, when it usually comes to these things, it's never just one thing. So just full disclosure, I have never been to Homewood. I've never been to Bellwood. I have never been to inpatient treatment as a patient, although I did do my own treatment when I was doing my training and sat through 28 days of treatment, although I got to go home every night. Mm-hmm. So I don't have an experience with that. I do know that the healthcare professional streams at Bellwood and Homewood do have a healthcare professionals stream, whatever that means, whether it's just the caduceus group. But I do know that there's no other ones that have that, as far as I know. I do know that they were considering, Homewood, I believe, was considering having a healthcare professional stream on the island. I don't know what the regulations are in terms of setting that up. I do know that it wasn't successful, because I think there's a demand for it for sure. I don't know what the holdup is. I was waiting for it, and then the next time I talk to them, it's like, hey, whatever happened to that? And they're like, yeah, no, it's not going to happen. But I don't know the logistics. I don't know if it's at a Ministry of Health level. I don't know if it's a credentialing, like through the assisted living registry. I really don't know. And I'm not the one that makes those decisions. All I know is that the requirements for healthcare professionals is that they have to go through a healthcare professional stream. I don't know what qualifies Homewood and Bellwood is that, other than the caduceus group. But that's kind of, above my pay scale, to be honest. I don't get to make those decisions as to who's what.
Okay. So if there would be no way for a layperson to kind of call somewhere and get somebody to define what a healthcare stream is.
I don't even know if I could phone somewhere and get that answer, to be honest.
Okay, no problem.
These are the two designated facilities in Canada for healthcare professionals.
Okay.
Yeah. Because it would be really easy for Edgewood to actually just, have a healthcare professional stream. They got almost 200 beds. Like, they're a well-recognized facility that is now, owned by one of the big two. I don't know what the holdup is in terms of getting that designation in an IMO.
Yeah.
Seems easy to me, but I don't have all the answers.
I did a calculation once based on what I knew about the flow of BC healthcare professionals going across versus, and looked at the cost of what it would be for the same treatment here in BC. And the number was quite astounding after a year, the difference, right? Yeah. And that's taxpayer money. So I don't understand why the government wouldn't, you'd think there'd be some red flags going on there. But like you said, sometimes it's hard to tell what's going on at these levels. And maybe there's something else involved that we're not privy to.
My hunch is that nobody's ever brought this up and looked at it until somebody crunches those numbers and brings it up and looks at it.
Well, that's crazy.
I would agree. But you know what? I personally, at the Ministry of Health level, I think most things are kind of crazy. But
yeah,
like, these things are really out of my control. I mean, I do what my training is advised me in terms of best outcomes for healthcare professionals. For example, like the average Joe, I know physicians who have kept Demerol on their desk to use at lunchtime, right? The average Joe doesn't have to deal with things like that. So we do have some unique challenges where people can go, because that's the designation of that facility. It's really out of my control, to be honest.
As far as available treatment facilities, yeah.
Right.
Could you maybe illuminate a little bit about why did they set these programs up to be that short? Is it strictly a money thing? Because, if we were looking at, we know that the evidence suggests benefit only after a certain period of time. Like, you don't... Yep. I'm sure you're aware of the 90 days and how all of a sudden you see some real benefit there. So not only are we sending people at a greater expense, but the time is too short to have any measurable effect.
So just so you know that, I think this is a good starting point, excuse me, but I do know people who have gone to the US and been in treatment for 8 months, 9 months. So I think it always has to be a balance between the monetary amount, because people were often paying for this out of pocket, versus how much time they needed off. But we know that recovery starts after you leave places like this, and they just give you the tools to use once you get home. And traditionally, I think it used to be only 28 days, which I agree. I don't think it's long enough. But how much more is the cost associated with staying for 3 months? And part of it is, resources. So when I set up this 20-bed inpatient facility, I had set it up for a 90-day inpatient stay, because oftentimes, because it's fully funded beds, they're going to be people who are quite marginalized. They've probably been to treatment once, twice, 10 times. And obviously, if a 28-day and a 42-day didn't work for them last time, maybe they need a little bit longer. And I was told in no uncertain terms from the health authority that they can't fund a 90-day stay. They have to put people through, because it's about, limited resources versus, the cost associated with treating just that one person or maybe two.
Yeah, I get it. So it's more of the same, where it's we don't care how effective the treatment is long term. We just need optics, so we got to get as many people through, regardless of
right.
Even if it's so ineffective.
And so my take on things is I don't care what people are using tomorrow. What I care about are they alive in 5 years? Are they happy? Are they using substances? And if they are, because some people do, are they using it in a healthier way, whatever that means, whether it's coffee or cigarettes or work or exercise or gambling, whatever. And are they living their life to their full potential? Because that's what it's about, not tomorrow, but that long term. But I don't think people who are making these monetary decisions are thinking that, because they're not frontline workers, for one thing. They don't understand addiction. They're pencil pushers making, business decisions.
Right.
Yeah.
Mm-hmm. Yeah, that's an understandable disconnect for sure.
Yeah.
And a good explanation.
It is. And I was just thinking about you describing it as just about building and developing the tools for when you finish the program. And I did a 1 month outpatient program, from my kitchen table.
Yeah.
And to the credit of the program that I did, they really did explain it as such, just that this was about, it was very much like sitting in on a university course where you're just kind of condensing it and packing it in to try to build the tools, and the hard work is kind of after. And looking at it that way, for me, I think I kind of did look at it that way, that like this in itself isn't what is healing me. This lesson, I learned lessons along the way from that, but it was the application of those after. So maybe for anyone who's listening, that's kind of a helpful mindset to maintain, that it's the application of the tools that we learn in those classes, if you will,
right,
that will benefit us later on.
And I think we have to remember there is no cure for the disease of addiction, but we can learn to manage it really well. And so, I don't consider my role as fixing anybody or treating, like this illness. It's about co-managing with the patient and educating people on their illness, why they might be feeling certain things or going through, withdrawal or whatever. But at the end of the day, recovery starts in the community when people go back home to their stressors, their jobs, their wives, their lives. And I think it's about managing all that, because we know that there's no cure.
Yeah, no, I think that's well said, and maybe the at least for me, I think that was what set me up for success so far. Was like it's about daily management and about the things that I apply on a daily basis, weekly basis.
Maybe that goes back to the healthcare professional stream, where the healthcare professional stream is a caduceus group, which I think some people call it an accountability group, where people's
Mm-hmm.
I hate to say this, but feet are held to the fire. And if they're not doing, stuff for their recovery, which doesn't really happen in, like a regular 12-step kind of meeting. So I think, part of this is that these recovery starts in the community, and part of that caduceus group in 90 meetings in 90 days is part of that community that can be helpful or maybe not helpful, because a lot of people don't like 12 steps and things like that. But I think it's where you kind of learn what your options are and what the tools are, and then you get to go put them in practice. But if you don't do well in that, like let's say, Corey, you didn't do well on an outpatient setting for 28 days, and let's say that you know, had a relapse, then the next step would be the next more intensive one. And it's based on the ASAM criteria, which once again is out of the US, that if your illness is at a certain level, perhaps outpatient treatment would be appropriate. But if it's, you know, you've tried that and it didn't work, or maybe you have some comorbidities like PTSD or complex PTSD, then maybe you need a 42-day, because you know, I also find that I think patients are more complex these days. You know, it's very rare to have just somebody with an alcohol use disorder anymore,
Sure.
or opiate use disorder. You know, because we've recognized things about trauma and, you know, adverse childhood events and, you know, sexual trauma. So I think patients have gotten more complex, and maybe we need even longer than that. But I think it always will balance down to how much can we afford? How much time can you be away from work? What are your goals? Like, because I have some single parents who can't be away from their families for 3 months, right? So I think, you know, you have to take all that into consideration, and also the severity of the illness as to what people might benefit from.
Yeah, great answer. Thank you. You know, I think I also, it makes me think about my willingness, or anyone's willingness, to then accept the treatment plan that is kind of laid before them. And if they say, that doesn't work for me, that doesn't work for my life,
Right.
then it certainly is not going to probably get very far, is it?
Well, and I don't know how much you guys come across this, but with some exception, usually people who have reached out and said, hey, I need help, those people are willing to accept a diagnosis. But even that treatment, you know, sometimes it's kind of like, what? Like, you want me to do what? But it's people who may not have come forward themselves, people who, you know, may have been found to be intoxicated at work, or somebody, you know, smelled alcohol in their breath, whatever. Those people usually hate seeing somebody like me. They're very angry. They don't buy into the diagnosis because they don't think I know what I'm talking about, which may or may not be true. But it's that resentment, that anger. And then you tell them you got to go to treatment for 42 days in a different province, and then you got to do all this hoop jumping with medical monitoring. That is part of the hardest part of my job. But I can tell you, most people, with some few exceptions, about a year into monitoring, they often will say, hey, you know what? This has been really good for my life. I didn't like it at first, and sometimes I still don't like it, all this hoop jumping, but my life is so much better. And most of the time they say thanks, and that feels really good. But it does take some time for that resentment kind of thing, and, you know, accepting the diagnosis and all these hoop jump recommendations that seem pretty cookie cutter to many people. I think that's a challenging part of my job. Yeah.
It must be. It must be. I think about, like, you must be very adept at challenging conversations and facing someone who's angry on the other side. You must
I think you get a thick skin after a while. Like, I mean, but to be fair, I have had many people, you know, have monitoring agreements with other people where things that have not always gone well for them, right? Because nobody likes to be told what to do. I don't like to be told what to do. But, you know, if you explain it in such a way to a patient that they go, okay, I get, I don't want to do it, but I get why I might have to. So, for example, you know, if I have a plastic surgeon who, you know, was found to be intoxicated in the OR. And then he's got to go through a monitoring program. And he goes, you know, I'm only going through divorce. I only drank a couple of drinks, and you know, like, it was just a one-off thing, which is fair. That can happen. But now he finds himself where somebody's reported him. Now he's got to do monitoring, and he doesn't understand why, because he doesn't drink a lot. He only drinks maybe once a month or something. The problem becomes whether you're a plastic surgeon, an orthopedic surgeon, or a RCMP officer, is we know in all these areas of occupation that bad things happen. Like, the tasering event at the Vancouver airport where a new immigrant died. So when people find themselves in that situation, if anyone were to ever find out that this person had a substance use disorder, as let's say a college complaint or RCMP internal investigation, the focus becomes whether this guy is actually abstinent, whether he's doing well, and whatever, and it becomes the main focus of that investigation instead of, hey, you know what, this guy was drunk and maybe that's why he died, and he was in delirium tremens, whatever. So the point of medical monitoring, yeah, it's to protect the public for sure. I think that has always been the primary goal and how things started. But at the same time, it's about dotting the I's and crossing the T's so that when bad things happen to a plastic surgeon who has been found to be intoxicated in the OR, the focus becomes on what actually happened to the patient as a medical problem, rather than is this plastic surgeon, stable in his recovery. That should never be a question in any complaint. So part of the monitoring process is equally to protect the employee or the RCMP officer or the nurse or the physician as it is the public. And when you explain it to people that way, they go, yeah, okay, I get it. I still don't want to do it, but I get why you want me to do this. Because if you explain to people why we're asking them to do things, it's a little easier of a buy-in for them than being said, okay, you know what, every so many days you're going to get called for a random. You have 24 hours to go do this sample. It's a hoop jump, and you have to go to caduceus meetings, and you have to do this. And they hate you because nobody likes to be told what to do. I don't know if that makes sense, but...
Sort of. I think that there's definitely people that would accept that explanation of it. Yeah, the when I look at the optics of the situation, I look at it as more of a maybe the employer, such as like the RCMP, are very concerned with optics all the time, right? It's a big part of their. So as a governing body or whoever's responsible for them, of course they're going to say either you get this problem under control or we can't have you on the force.
Well, actually, I mean, you can't be fired for a substance use disorder. It's considered a disability. They have to accommodate you, right?
Yeah, but I mean, I just think as far as it convincing an individual that this is not just a liability issue, would be
no. It's a huge liability, and that's a primary reason why all this started.
Yes, like these are colleges, regulatory bodies. They don't know what to do. The evidence is scant, so it's kind of I see a lot of hot potato type stuff going on where they legally are bound to try to get this person back to work. So they're stuck legally that way. There's a procedure that's sort of been carved out. So they'll send a person to see somebody who will then, they have a much better understanding of the addiction, of how the behavior develops, the impacts of it. And then it becomes, is this person qualified to say that this person is salvageable? And if so, what do we have to do? Well, that's what we're talking about, right?
I don't know if salvageable is the word I would use.
Well, I mean, I think that's really what, like, look at how nurses are treated in general by their health authorities. Would you say that the people who are in control of those health authorities genuinely care about their nurses, or is it a little mechanical, perhaps, the way they're...
So, health authority means HR.
Yes, it does.
Most HR do not understand addiction. But to be honest, we have the LEAP program in BC, and it's actually the only and best one that nurses have in all of Canada. Like Ontario, which has more nurses than we do, does not have anything close to LEAP. And in Ontario, one nurse would probably tell another nurse, if you have a substance use disorder, never disclose it, because you will find yourself on a path that you never thought you'd be on. At least, and this is one of the problems with not only the track of, safety sensitive individuals, but I think, one of the questions you had asked me was, why did I get into the field of addiction medicine? And that was because, you don't know this, but I used to be a pathologist in my former life, and I was training to be a pathologist, or maybe
I do know that. Yeah.
Yeah. And, pathology is so different than every other area of medicine. I didn't have a lot of clinical experience. And when I was doing some training, I was appalled. I was appalled at how just the regular addiction patient was treated by our healthcare system, by my colleagues, by MOAs, by everybody, because, we have this certain image of what an addiction patient is or should be. And my goal was to bring addiction medicine into mainstream medicine. I wanted to have people not be embarrassed to ask for help, because, you guys know how difficult it must be for somebody to ask for help. And then when they do, it's the system and my colleagues that actually discriminate the most. So, when I first set up my office, I set it up as a boutique-y little place with white leather couches and a nice little environment, because I don't think people should be ashamed to ask for treatment for substance use disorders. But that's still the case right now. And that's the part that I really dislike. So in terms of, going back to the nurses, is it a great system for healthcare professionals or any safety sensitive individual? No. And I don't know that it's ever going to be honest. I think our healthcare system is atrocious right now, and particularly in addiction, it's even worse. But I think unless we're having these conversations, we're not going to ever make it better either.
Well, that's what we aim to do.
Yeah.
And you're right about people feeling a certain way about disclosing. We've done several episodes on the power of language and why it's important. How you identify yourself as an individual has an impact on whether or not you are able to make the changes or grow as a human being to the point where you've got your life back together. But yeah, given the current situation, it's hard to, can you imagine that there would be a single person out there if they knew what they were facing?
No.
Right. So that's a huge problem.
That's a huge problem. And, you and I were talking earlier about me being off work for a couple months in 2019. It was a bit of a rough year. It was I was burning out once again, and I used to do a fair bit of work for the PHP and treating physicians through IMEs and monitoring.
What's the PHP for our listeners?
Oh, sorry, the Physicians Health Program.
Okay.
And so while I was on the phone, I asked this lady, hey, I just want to know if there's a place where physicians can go if they're being bullied in the workforce. And she said, well, let me open up a file for you and I'll look into it. And I can look into it. Yeah, she gets back to me a couple of weeks later. Yeah, there's nowhere. I'm like, well, it's a good thing I'm not being sexually harassed, because there's nowhere for physicians to turn to. We can't go to the health authority. We're not employees. We're independent contractors, and apparently, according to Interior Health at least, we should all be big boys and girls and play nice in the sandbox. So, a few months go by, and, they've got me talking to, a physician who's very helpful. But somewhere along the line, somebody had enough concern about me that they thought I should have an assessment to see if I was depressed. I'm like, you know what? I don't know what depression feels like, but I don't think this is it. I think I'm burnt out. I think I'm just done with my job, and it's all the system problems. And so then they decide, well, I need to have this assessment done, which means they're going to put my license on temporary hold.
Hey, this all sounds very familiar, right?
Well, yeah. And so, but you can imagine if I do opiate agonist therapy, most of my prescriptions are going to be an opiate on a triplicate. And they are all going to expire as soon as my license is put on temporary hold. So not only am I saying I'm burnt out, but it's the system that's saying, okay, well, we're going to cancel your license. And now you have to spend 3 days writing or getting somebody else to write narcotic prescriptions because yours are all going to expire in 3 days.
Mm.
Luckily, I said, like, guys, I'm not depressed, but imagine if I had a substance use disorder, they would have canceled my license on the spot, put it on temporary hold, further causing more burnout and stress in my life that I really didn't need. Is that really necessary? I didn't think so. But the weird thing is, I didn't even have a substance use disorder. I didn't even have depression. And I find myself on this path where just because you have some, mental health stuff going on, including burnout, that we are somehow treated inferiorly than anybody else in the healthcare system because somehow we're just inept or not safe or whatever. And it was kind of a resentment, to be honest. I didn't want to come back to work. Not if that's how I was going to be treated. And I work in this area.
Well, Mandy, that is just a remarkable parallel to what your patients must be feeling, correct?
Only worse, because they actually have substance use disorders,
right?
That are just another layer on top of that complexity and stigmatizing. And yeah, it's not good. And I don't know how to change it, to be honest, because remember I said I went into medicine to bring addiction medicine into mainstream medicine, and I don't know if that's going to happen in my career.
Well, I'm kind of flabbergasted here. I mean, how do you must experience a tremendous amount of cognitive dissonance.
Yeah.
Huh.
I mean, I have colleagues of mine. So we have a consultation service at the Royal Inland Hospital, and I've had, I won't say what specialty, but I've had my colleagues say, "Why do you do this kind of work? Like they're just going to go out and relapse." And I'm like, they might, but they're for sure gonna if we don't offer them some help, because you can't write people off because they have a diagnosis, and that's what we do in addiction medicine. We don't treat them the same as we would a palliative cancer patient. We don't, and palliative addiction medicine is what you see when you drive around the streets and people are living on the streets. That's palliative addiction medicine. And it's so much easier to treat people long before they get to that palliative stage. But we don't do it. But the key thing is early intervention and repeat intervention. And if we don't have colleagues that are willing to do that because we can't treat people with the respect and dignity that they deserve, then it's never going to happen, right?
Okay. Yeah, that I'm still reeling a little bit here, Corey.
Did I say something to make you realize? I'm sorry.
No,
what did I say? What do you need clarifying on?
No, it's clear. It's just, like I said, I mean, I can't. It was that type of cognitive dissonance where I felt powerless. I'm talking about my job now, where I would see somebody who was in pain, or I would see somebody who needed help, and a lot of times I could help them, but the system was trying to prevent me. These days, I just do it. I don't care if somebody wants to, take my license because I gave an old lady with a UTI something on a Friday. Take it. I don't care. But not being able or being able to or being a part of a system that is so incongruent with what my values are, I believe was the primary driver in my seeking solace in opiates.
Yeah. Yeah.
And yeah, I mean, it is a spirit killer, when you're.
I think it maybe that doesn't happen in just addiction medicine for sure, because I know a lot of my colleagues just in medicine are experiencing like a moral injury that,
Yes.
yeah,
Yes.
and it's a struggle sometimes just to get to work and feel like you're doing the job that you want to in the manner in which it needs to be done.
Yeah.
And I don't know if that's such a thing in medicine anymore. And part of it is, resources, limited resources, and lack of funding, and long wait lists, and complicated patients, much more complex than even like 10 years ago. But it is for sure a moral injury. And that's why I think there's more burnout. That's why I think there's a lot more reliance on things like opiates and alcohol. I do know that when the first December of COVID, we had a lot of previously pretty high functioning individuals, whether they were healthcare professionals, RCMP members, teachers. By December of 2021, they just weren't doing well.
Mm-hmm.
And so I think if every layer on top is just another insult, and I don't know how that's going to change, because I think these are all system problems, other than COVID, obviously.
Yes.
Yes. I first of all, I really commend you. I don't think I've ever had heard so frankly from a physician about burnout and
remarkable.
About bullying and some of the culture of the system. So what I wanted to ask was are we in fact talking about a drawback of the public healthcare system, that the nature of it, that it needs to be self-propelling by way of all of its different facets and different human beings that are keeping it propelling forward?
Define
There's something intrinsic there.
Define self.
Just that just keeping afloat.
I don't even think we're floating right now, to be honest.
No, we're sort of
we're taking on water. The bow is
certainly,
definitely, yeah,
certainly. Yeah. But by keeping self-propelling, by keeping afloat, ideally. So, is there something intrinsically in that where silence is an essential part of it, like where it silences people, silences a physician who's burning out, silences a nurse who's diverting opiates, like.
Well,
it certainly feels that way. I don't think there's a great, at least from a nursing perspective, I don't think there's a great ear for people who are expressing their concerns either with the system or their feeling of burnout or fatigue or moral distress. I think I end up, and this is coming from there's a bitterness behind this statement, that I think I was a more valued employee when I was just trying to keep my shift together and forge ahead.
Yes, that's right.
And so it creates a feeling of from the healthcare system itself, from the health authorities itself, a feeling sort of dispensable or disposable, rather.
Yes, because I actually, some of the times when I was working under the most pressure, the most responsibility, in the fastest pace, that's when I was, I would use a consistent amount of opiates to get through it. But as we discussed before, that's where I got most of my accolades as a pharmacist. And it was because, I was pushing it where I think a person who wasn't getting that extra empathy or calmness of mind or whatever from that drug would have just thrown their hands in the air and walked away. That's not as useful to the organization, obviously.
Nathan, I want to really say thanks, because what you just described, I don't think a lot of people would have said, but I am a firm believer that if we don't talk about these things, whether it's physician burnout or whether it's substance use, whether it's mental health, I agree, Corey, that there is no ear. It's not even a great ear. It's not a listening ear. It's not a sympathetic ear. There is no ear.
Mhm.
And to be honest, I'm kind of sick and tired of it. And this is part of the problem.
Mhm.
That, even for myself, I mean, Nathan, I think you know that I've been burnt out several times. And oddly, it's not surprising from what you're saying about the best accolades or when you weren't doing well, but you were this super pharmacist kind of, on the fly with your Superman cape. Well, the compliments that I got the most was when I was not doing the best. It was when, I think you knew that I had started that conference in Kelowna.
Mhm.
And I was burnt out and I was doing everything off the side of my desk. I was doing way too much, not only at work because, the health authority has all these meetings that you have to take time off work. So you lose income. You go sit on these health authority meetings where they're all getting paid a salary to attend, but you're losing money. Like that is a real resentment for me.
I bet.
Right? But who's listening?
Mhm.
So then you say, well, I'm going to have some boundaries.
That's all.
And,
Yeah.
but to get to that stage, you have to go through some shit to get to that stage.
Mhm.
Because if I'm being honest, people don't get to be in positions like ours where we're successful and needed and getting accolades by saying no.
Right.
We get there by saying yes and not knowing how to say no. And
Yes, absolutely.
right,
That's
yes. So you said yes again.
yeah.
And I think saying no is a learned thing that you can only learn after you've been burned a few times. And I have done that. I have said, I'm never going to do this again. I'm never going to do lectures. I'm not going to do presentations. It's all work for free. It's burning me out. And guess what? Last night I did a lecture at TRU for free. Like, because there's that slow, steady creep that happens.
Mhm.
I don't, other than quitting medicine, I don't know how to get rid of that because I haven't learned how to say no very well yet. And it's a work in progress. It'll be a work in progress until the day I die. But balancing that with, I've been a single parent for many years. I've got two boys who are now much older and they're great young men, but those are really the priorities in my life. And I find that all of this fluff that is my career is just really fluff because it doesn't define, I don't want it to define who I am, but apparently it does sometimes. And I'm kind of tired of that too. I just want to go home and be a mom and be a good mom. And I think I am when I'm around. The problem is I'm not always around. Right? And despite that, they've turned out pretty well, but I thank my lucky stars that they have. Right?
Well, yeah. I mean, I could only imagine how people are going to receive this
Oh, no,
strange situation because what you're saying there is just such a human statement. And especially doctors, I think from the get-go, because you guys, we really pump you up. You are the pinnacle
that's
of
the
our
problem.
and you get this kind of right out of med school, you're just kind of shot out of a cannon as far as praise is concerned, and that you're such an important part of society because of what you know in your knowledge base and your education and stuff. And I think, I mean, we've talked about that, Corey, where the identity, how insidious it is in getting into your the core of your being, and how it then makes it another layer of difficulty when you're trying to say no to these things that are related to your career because you believe it's going to somehow hurt you, like the essence of who you are, and it's
Yeah.
not really going to.
Well,
You know,
I think it's that perception. You're right, that essence of who you are, because you're right. You get pumped up, yeah, first week of med school, but you've also worked like your ass off for 4 years just trying to get to that point. The problem is this is what leads to imposter syndrome, right? And it just further devalues your own impression of yourself. Because, I mean, there's a lot of smart people in med school. But the problem is there's a lot of dumb people in medicine too, and you don't really see that as much because you compare yourself to whatever. But I don't think that's a good system to pump people up, because then when you go work for a health authority, they really don't value you. You're going, what the hell? Like, you don't value me, like, you know.
It's great.
I don't know what the answer is, but I don't know. I think the bottom line is that, you know, what we see on the surface is the label you get, right? I mean, you know, if you drink too much, you're known as an alcoholic. And if you use too many drugs, you're, you know, an addict. And I don't like that word, but that is what people use. But, you know, if you're a gambler, you have financial problems, or a shopaholic or sexaholic. But if you work too much and that's how you get your dopamine, you're considered part of a noble profession called medicine. But it's still unhealthy, right? It's very unhealthy, because unless you have balance in your life, it's all one-sided, and that's all you're getting your dopamine from.
Yes. Yeah. Well, this is what I mean. The whole thing is about manageability.
Manageability,
right? I mean, it doesn't matter whether you're using a drug or whatever behavior that you're reinforcing to the point where it becomes a habit or a compulsion, and you've got to a point where it's on autopilot. You've literally changed the way your brain works because you've sustained this habit for so long.
Yeah.
This is a manageability problem. And it's, you know, it's secondary to our way of life and the nature of our society and stuff. But I don't believe there's a big difference between, you know, working too much and taking drugs, other than maybe the drugs, you know, you're working with something that might elicit a compulsion faster. That's all. Because but if you work and work and work and work, it'll do the same thing eventually.
Yeah, it will. It's just, you know, we as a society think one is worse than the other.
Yes.
Right? Because we pump people up who are working too hard and don't know how to say no, and look down upon everybody else who's actually using a chemical to do the same thing.
Mm-hmm.
Yeah. No,
yeah. I look back at myself and the number of 16-hour shifts that I worked at the beginning of the pandemic, and the accolades I got for that, the affirmation and the strokes, and oh, Corey, you're just so great. I was exhausted. I was using hydromorphone, which no one knew, and simultaneously feeling like an imposter, but also getting this feedback of you know, affirmation. I don't think I stood a chance until I was fully removed from that environment and disconnected from that. And it makes me feel a sense of empathy for the people that are locked in that dangerous cycle. Dangerous cycle.
It's a vicious cycle. Yeah.
Yeah.
You know, you asked me about, you know, why I went into addiction medicine. Well, when I changed out of pathology, I had no idea what I was going to do. But being the oldest person in my medical school class, the one thing that everybody expected me to do was family medicine. So I knew damn well I wasn't going to do that, because I don't like to meet people's expectations. I like to think outside the box, right? And so, not knowing what I wanted to do, I did some extra training, and one of them was just like, I didn't know what to pick, so I chose addiction medicine. And you know, part of that training, I went to self-help meetings. I sat through a 28-day inpatient treatment, but like I said, I got to go home at the end of every night, unlike the rest of the patients there. And it was a time in my life where I was really struggling with all of these things. It was about, you know, what defines you as a person, and you know, how do you say no, and how do you, you know, acknowledge that you went into a field and, you know, it wasn't necessarily the best thing for your marriage or your kids or your family or whatever, and really feeling some guilt about that. But it was actually the 12 steps that really, and I don't have a problem with substances, but it helped me to become a little bit more grounded with all those cliche things that people talk about in meetings. You know, it was a place where I felt welcome, that people didn't judge, that it was about living one day at a time. It was about living and letting go, because letting go is actually, even now, like when I look back in 2019, letting go is probably one of the hardest things that I've learned how to do. And it was a time in a place in my life where I was struggling, and I really resonated with, doing that internal work. And I think, maybe we have a long ways to go in terms of how we treat addiction medicine patients, or mental health in general, whether it's, moral injury or burnout or depression or anxiety or whatever. And I'm hoping that in the next 20 years, we have a long ways to go, but hopefully that will improve how we treat mental health and how we treat mental health patients, more importantly.
Mm-hmm. It is certainly, compared to when I started my career, certainly talked about more. And in the last, I think that has been one of the best things to come out of the pandemic of the last couple of years, is that it has illuminated the discussion of mental health quite rapidly, I think.
That and the poison drug situation.
Yeah.
I mean, that.
But it's still system problems. So,
yes.
You can say that, you were burnt out and you were off work for 2 months, and then you get denied like life insurance. Like, hello? Like, I didn't kill myself. I never said I was going to kill myself. And even if I did, does that mean that I should be denied a basic thing that every other person is entitled to?
Welcome to the machine, Mandy.
Yeah. It's a bit of a vortex in the machine sometimes, and not a place I always like working. And don't get me wrong, I love treating patients. I like working with them. It's all these system problems that
this province, for all its progression, I mean, if you compare it to, like you're mentioning, Ontario, the way that what the options the nurses have there, or even Alberta is a lot different. I mean, it's like our boat is pointed in the right direction, but it's so covered in red tape that it's sinking.
Yeah.
If we could somehow get a little bit of common sense going, and I know.
I don't think there is any common sense out there. That's the problem.
It's in short supply right now, like everything else. But
I think part of it is that you have multiple arms trying to turn this ship into whatever direction it needs to go. So, we have frontline workers, we have middle management, but then really the people that fund these things are people that are in government, whose main mandate does not look past the next election.
That's right. Yeah. I mean, that's the main problem. And it's too big for a discussion here. I mean, we could tackle it, but we got to try to keep you focused on our little questions here.
Okay.
So maybe I'll bring us to number 2. That
sure.
Certainly in even just thinking about Suboxone and opioid agonist treatments in general, the understanding within the healthcare system has increased. I think I can remember sort of the genesis of Suboxone, and the universal misunderstanding was profound. Now we're seeing, that even governing bodies and unions are starting to, they sound like they're more open-minded to the idea of a healthcare professional requiring Suboxone for a period of time. There's been lots of debate that Nathan and I have heard and participated in about whether or not opiate agonists are appropriate or inappropriate in the setting of a healthcare worker being at work. So we were hoping that you could help us in this discussion.
So I think I was of the mind, things have evolved, obviously. I was of the mind that because the it's called the oh God, I have to think of the name, American College of Environmental and Occupational Medicine, which I'm a member of. They've got lots of studies.
Mandy, is there any medical board that you do not currently sit on?
No, I'm just a member. I'm not on the board.
My God.
It's because Canada doesn't have great rules. Like most of these rules either come out through the Department of Transportation out of the US or the state Federation of State Physician Health Programs. So all of these rules kind of come out of the US where their research is a little bit more robust. And they've got a collection of, articles, white papers that any opiate, whether it's methadone or Suboxone to a lesser degree, because buprenorphine isn't as, it's not that it's not rewarding, it just doesn't cause the same cognitive effects as, say, methadone would. That there is some cognitive impairment with any opiate. And so they kind of use these as general blanket rules without necessarily limiting it to, can a pharmacist go to work on Suboxone? So, I have to kind of follow those guidelines because they're not even guidelines, they're recommendations for what they're worth, because there's nothing in any literature that I have ever read that says, yep, it's safe for people to go back to work on opiates. So it's different than saying, can they? Maybe. Is there evidence to show that opiates are impairing? Sure. Is there evidence to show that opiates are not impairing? And I don't have that evidence. So number one, that kind of helped to inform my decision. The second thing is that if you enter into a monitoring agreement, the first thing it says is you will not use substances of potential abuse, whether it's Gravol or to excess or whatever. And we know that Suboxone is abused by some people who are not necessarily using opiates on a daily basis. But if you don't use for a while, you can get intoxicated from buprenorphine. There's no reason why you couldn't, or you couldn't take enough of it to, get intoxicated. So when all we had was Suboxone, that was, maybe given a couple of weeks of caries or whatever, I did have a problem with it. And one of the reasons is an example such as this. A nurse who is on Suboxone, she gets caries. It's not prescribed by me, obviously, because I'm not her treating physician. She's getting it through a nurse practitioner who doesn't even know about the Health Practitioners Act and the duty to report. So she started her on Suboxone. But this nurse is not always taking the Suboxone, because what she does is she saves up enough that when she'll go without for a couple of weeks, then she can take some hydromorphone from work and use it because she doesn't have any Suboxone on board, and then she'll wait a little while and go back to her Suboxone. There's no way for us to tell in our current system, just simply by doing urine drug screens at a random or not, is this person taking the medication as prescribed? Are they saving it up for a rainy day and using it when they're bored and getting intoxicated? And are they, at risk of relapse if they run out of medication or whatever? Because maybe intentionally or not, because sometimes they miss their medication intentionally, so they can use. However, I think with the advent of Sublocade, it takes that out of the picture a little bit. I don't have to know whether this person took their Suboxone today or whether they're hoarding it or whatever. I know that I can look on PharmaNet, they're getting it once every 4 to 6 weeks. And that is enough not only to, treat the withdrawal and cravings, but also to prevent overdoses if they do relapse. So that is a huge thing for me, because I think just to say you can be on methadone, I don't think I think methadone is quite cognitively impairing, depending on the dose. So I would definitely say that people in safety sensitive situations should not go to work on methadone, partly because the withdrawal from methadone is actually worse than withdrawal from heroin if you miss a couple of days. But two, if you go up in doses, it can be quite cognitively slowing. And so I would certainly rule that methadone should not be used in safety sensitive individuals going back to work. I think buprenorphine is a different molecule, and I really like buprenorphine, but because we can't tell in a monitoring patient whether they're taking their doses on time, are they taking their doses as prescribed, are they saving it for a rainy day, I think the Sublocade option is a much better option for individuals. And I don't think buprenorphine is as impairing, because I don't know if you guys know this, but people have told me that a buprenorphine, their mind is really clear. It's not slow. It's like, the colors kind of come back on. They're more activated than they were on other opiates, whether that's good or bad. But the real question is, what do you do when this person is not in a monitoring program anymore? They've done their 2 to 5 years of monitoring. They're still on Sublocade or Suboxone, and then they're going to taper off, because we know that many people in the general population, at least, because we don't have the evidence to know this in safety sensitive individuals because they're typically not on opiate agonist therapy. We know that in the general population, when they get down to that last 2 milligrams of Suboxone, that's often where they might relapse. So I mean, it's a double-edged sword. I think, my thinking has changed for sure with the advent of Sublocade. I love Sublocade. I think patients do really well on it. I think there's still some challenges with, people who are going to eventually want to come off of it, because I'm also of the firm belief that if you are managing this illness and you're doing all the other things, I don't think you need to be on opiate agonist therapy forever. I know that there's other physicians that may not feel that, but I don't really think of it as a lifelong medication. I think there's a time and a place for it. And I think many people do well in life and can eventually come off of it. I just think we need to be mindful when safety sensitive individuals, like, for example, a nurse is down to the last little bit of Suboxone, and monitoring, that person for relapse. Because I think, remember, I said for me, this is a long-term view here. Are people alive? Are they happy? Are they living their life to their full potential 5-10 years down the road? And that's when they might be coming off their opiate agonist therapy. I still think it's easier to come off of opiate agonist therapy with Sublocade, and I've had a lot of non-safety sensitive people do that without difficulty. Yeah.
Does Sublocade interfere with urine drug screen?
Yep, it's buprenorphine.
It still does. Yeah.
So, that's part of the thing. We have to modify that monitoring agreement that says you will not use opiates and other substances with abuse potential. And then the first thing you do is you come up positive for buprenorphine.
I just want to, I agree with the Suboxone's usefulness, and I think that, like you said, a time and a place is a great way to state it, because take the Vietnam data, for instance. I mean, it's a great example of when you're in an environment that is causing you to be so, whatever it is, giving you such emotional distress that you need to cover up with something. That's the area where you're gonna see an escalation or out of control use of whatever the substance is. So say you've got a nurse who's in acute care, they're taking Suboxone. Now they're going to move out of that. They're going to go renal or something. Not a big deal. I would still keep an eye on them as they get down, because people tend to taper too fast. I've done that myself. You think that you get all excited and you think you're my girlfriend right now is a physician, and she is a fantastic opioid taper expert. She really showed, like, she's had great success with patients by communicating that tendency to go towards wanting to come off it quick, because people want to, okay, I'm done with this drug, I don't need it anymore, whether they're chronic pain patients. And I understand it because I've done the same thing. But it's really, if you go slow and you go low, it might take some time, but you'll get there, and it's not going to be the hellfire.
Well, I mean, like her, I think most of my job is about educating people on their illness. And typically, what I say is there's only one way to get off of opiates, and that is as slow as possible. This is a marathon, it's not a race. Because if we want good long-term outcomes, because I don't want to see you back in my office in 6 to 8 months, because that's what happens otherwise.
It does. Yeah.
And of course, there's all the post-acute withdrawal and the severe depression, and then I've done nothing except put them at risk of overdose, like a couple months out when they're feeling depressed and suicidal and can't sleep and all that. But I think a lot of this is hand-holding, but I don't think, and again, it's a system problem. I don't think our system lends well to hand-holding because time is money. And I think people, physicians or nurses or whoever that do this because they care.
Yes. Yeah. It's not like you're going to, well, we'll see. I mean, the new physicians deal looks a little better in that regard, but we'll see what actually comes of it.
But money can't make you care. Because
no, it certainly can't. But what I'm saying is those types of people, those types of healthcare workers they don't always think of money. They're trying to actually help because they're people who want to help people.
One of my jobs right now that I find challenging is I have a whole slew of young men from about 18 to 28. They're all buying benzos online, and they're like these Cherry Noble like benzos that come out of Russia, and they get in little birthday cards in the mail. And so we don't even know the half-lives. And I find that challenging because it's a half an hour appointment to talk to this guy. Mm-hmm. But you're either going to kind of do that work or you're not, right? Mm-hmm. And so maybe it'll encourage more people to do that with the new, it's not the master agreement. It's this side deal that we have with the BC government that, means it can change anytime, right?
Yes, I'm very cognizant of that. And I'll wait and see what plays out in February, but I'm hopeful because at least they gave you something. And it was
hopeful too.
It was ridiculous before.
I know. And if I'm being really honest, if there was any way I could have closed up my clinic, I would have done it a long time ago. I just can't abandon my patients because one, I don't know where I would send them. Two, I'd probably get in trouble with my college. And three, I mean, there's got to be somebody that's doing it, but it is, it is not. I mean, this line of work is not easy, but it's more difficult when.
They're not paying you what you should be paid.
Well, because there's a lot of people that'll see 10 patients an hour or 6 patients an hour. I'm not doing that.
Yeah.
Because there's no way I could do that. And to be honest, I don't want to run a McMedicine clinic, to be honest. So the problem is the current environment it's about quantity, not quality of care. It's about fast care. And that leads to that, moral injury, that burnout, that how am I going to, pay my staff and, all these things. And I don't know, it's a struggle every day, to be honest.
Yeah, it certainly is.
Yeah.
We'll move on to this one. It's definitely a contentious question, depending on where you're coming from or who you're talking to. What are your thoughts on this conflict of interest stuff that we've seen in the news? And I've seen complaints launched and retracted online. There's a clinic down on the coast specifically that got reprimanded, and then they got cleared by the college. And basically what the conflict is there's concerns raised about physicians who are medical review officers. So they're in a position to set terms as far as, whether or not a person requires medical monitoring and how long they're going to be monitored. And then these same physicians sometimes have financial interests or actually own businesses that do the medical monitoring. Now, you are in this situation yourself. And I guess I'm just going to ask your perspective. I'd like to know what you thought about what happened there with the doctors down south and your take on the whole thing.
So let me just start by saying I've probably had more college complaints than any other physician I know. And that's simply because you cannot work in one addiction medicine, but more so in the medical legal aspect of addiction medicine, which is medical monitoring and doing IMEs. If you don't want to at some point be the at the center of a college complaint. I think this area of medicine generates the most. I've had a human rights tribunal against me, just so you know, and I'm still waiting for the outcome of that. And it's been since 2016. So I don't think you can be faint of heart if you're going to do this kind of work. Do I think conflict of interest exists? Absolutely. I think the case of the clinic at the coast is that it was an MRO. They did an IME. They referred to their own monitoring company where they also did their own drug testing. Like it wasn't just a collection, it was they owned the lab. And to be honest, that is probably the most lucrative part of all things. And they also did their own caduceus groups where there's a charge. And so, Nathan, that you were, I asked you to run the caduceus group because I don't want to be part of somewhere where my patients are spilling their guts and talking about their recovery. I don't think that's my business in a caduceus meeting. But there are many, many caduceus groups that run that way.
Yeah, and I can't believe that that's allowed, honestly, because
yeah,
I mean that right there it's a power imbalance that gets in the way of everything. Nobody's going to be honest in under those conditions.
Well, and maybe that's part of that system problem that I don't have the answers, but I don't know. You also know that there are people who do IMEs that will refer people to their own treatment center where they stand to make income.
Yes.
So do conflicts of interest exist? Absolutely. Further, in that case in Vancouver, it was further compounded because there's not a lot of people who I would say are qualified to do IMEs. They typically are MROs or people who are, a part of the Federation of State Physician Health Program, like I am and my company is, and some of these other guys that are top notch in their field are and should be. Because anybody can do an assessment, but is it given the context of that individual's occupation and the risks associated with that as they return to work? So I think, a lot of people can do IMEs. It doesn't mean that they should be doing IMEs, number one. So the other problem is that a lot of the licensing boards, whether it's a College of Pharmacists or a College of Physicians, Nurses, Law Society, RCMP, they want some of the people that are qualified to do this because they know what they're doing. They're not just some addiction doc that's decided that they're going to do an IME I won't say who those guys are, but they are out there. So in the case in Vancouver, it was a licensing board that decided that they wanted a certain person to do the IME, and that person referred to their own monitoring company, which has their own lab and their own caduceus group. Huge conflict, particularly because in Vancouver, there's actually a number of other places you can be sent to for monitoring. The problem is outside of the lower mainland, there's a paucity of services. So on Vancouver Island, we have Pegasus and they do IMEs, but they actually do monitoring all over Vancouver Island, all the way up to Port Hardy. And that hasn't really been easy for people who, there's no life labs there to send people for 24-hour collection within 24 hours. So it's a bit of a challenge. And outside of that, there's myself with Interior Medical Monitoring and one other company here in town where there's one qualified person to do IMEs and one person in Prince George who really wants to retire but can't because he doesn't know what he's going to do with all of his physicians and healthcare professionals that are up there that he's monitoring. So I wanted to read you something. Because this is a subject of a college complaint. And I think the key, and things have changed over time because, Nathan, when I first met you, things were really different and not as well organized in terms of monitoring IMEs or anything. And I think as these issues have come up, we're more cognizant of how we are perceived as people who are offering this service. And so I think part of it is that, you should tell people that you have a financial stake in monitoring companies. You should offer them other options so they can make an informed decision. And certainly that's what we do in writing. And this is what the last college complaint that I had said. We acknowledge that a perceived conflict interest may result. However, Dr. Manak is correct that due to the small number of qualified medical monitors, it is often difficult to avoid this perception. The college has provided advice to physicians stating the importance of minimizing such conflicts by various means. Dr. Manak has described the steps that she undertakes to avoid real or perceived conflict of interest when she is recommending medical monitoring. We consider her measures appropriate to her circumstances. And in that, it was the Health Professions Review Board about the case that we were talking about at the coast. One of the things that they have said is that, referring patients to your own business is inherently a conflict of interest, perceived or real, and is probably more real than perceived. However, there are some exceptions when this principle may be have some, rules to bend the rules a bit, I guess. So it says that the first exception to this general principle against referring patients to a business or facility in which the physician has a financial business interest occurs when the referral occurs in a community with demonstrated need, such as a rural community where there are no or very limited alternatives other than the referred facility. So, like I said, outside of the Lower Mainland, there's 3 people doing medical monitoring. 2 of them are in Kamloops, and 1 in Prince George, which is a very informal kind of thing. And he's just done it because there's nobody else up there. So I also think you have to tell patients that, hey, I have a vested interest in this facility. Here are some other options, and you can decide. Where some of the problems arise is, let's say the Law Society says, you know what, we don't like so-and-so's monitoring because they don't do 7 days a week, they don't do 24 hours, they don't do ETGs, they don't do hair samples. So we want to use Dr. Manak's service. That sometimes confuses the issue because now the Law Society says, well, you should go to Dr. Manak, and like you've already had your IME done by that company, and then people feel like they're forced to go. So I think part of it is that the regulating agencies need to say, here's a list of people, pick one. Your choice. And then, so we have, so I have another MRO that works for me in interior medical monitoring. I do the IMEs. And if they choose to come to Kamloops and have their monitoring done, it is never done by the person that does the IME. It is done by a different MRO. Will I hear that name from time to time? Sure. But I think, if unless you wanted to go to the coast, and recognizing that since COVID, we're actually able to do things like telehealth now. We weren't allowed to do that for monitoring before. So people actually had to drive from Cranbrook to Vancouver if they wanted somebody else. Mm-hmm. I mean, is that much of a choice, like to do that? At least now we can do some telehealth, but I think...
Can I ask you a question?
Yeah.
Why even be involved in that part of it at all? Like, I realize that probably it's because of financial reasons. But
why be involved in monitoring?
Yes.
But that's like saying, why, okay, so I've given you this example before. You're in a remote community in like northern BC, and you're the only general surgeon in town. You get a referral, you assess somebody, and they go, oh, you need a cholecystectomy, and I'll do it tomorrow. Is there a conflict of interest because the general surgeon is now also benefiting from the billing that he's going to get from the cholecystectomy?
No, but the patient has, it's not the same, and that there's incentive based on the duration of the contract that the physician is giving.
Well,
you understand? Like
sure.
if
So the problem is those are not arbitrary numbers.
yes, but by our nature as humans, we are not able to resist even our heuristic biases.
Right.
This has been shown scientifically.
Right.
You might have the best intentions in the world,
right,
but there might be an inkling, just a twitch of a push towards a longer monitoring contract because you know that patient is likely to go to you.
Those numbers, though, are not always arbitrary. So I hear what you're saying, but here's an example.
Okay.
So pharmacists are going to be able to prescribe as of next year sometime.
If there's any pharmacists left, but yes, please.
Right. So, we're told that physicians cannot be pharmacy owners. You cannot be a prescriber and own a pharmacy. I think I've talked to you about that before. But when pharmacists are now able to prescribe, and let's say the pharmacist owns the pharmacy, and now he's making a recommendation for this or that or the other thing, is that a conflict? Because he's actually selling a product that he's going to benefit from based on the price of that. So
yes, it is a conflict of interest.
So then why are pharmacists allowed to do it? Why are general surgeons allowed to offer an operation when they're going to benefit from it? Maybe the guy doesn't need his gallbladder taken out tomorrow, but maybe eventually. Is that a conflict of interest? So, in getting back to this mainstream medicine, I worry that we treat addiction medicine a little bit differently than the rest of medicine, and I don't want to do that. You asked me why I offer this service is because for me to be an addiction doc doing IMEs and not offer that service is like being a general surgeon who can make a diagnosis but not actually offer the surgery.
Or it could be like a judge that also has shares in a prison, right? I mean, it's kind of, I don't know how you could separate it properly so that you could be sure that the knowledge of some financial gain is not somehow influencing your decision.
But
unless you had guidance.
Do you see? I get the human nature part, and I totally agree with that. But do you see how that just adds to the moral injury that we already face to say that we do not have some sort of ethical guidelines that we go by? I'm not saying that all physicians do or don't, but for those of us that do, it's just another layer of that moral injury that we have to face because we're trying to provide a service that my patient does not have to drive to Vancouver like once a week.
I totally understand. And obviously there's physicians out there who offer the service and don't look at it that way at all.
Right.
Unfortunately, there are other physicians who go way further than even that.
Yeah, I agree.
And the problem is, you're basically, you're asking the public to take your word for it. And this is fine. I think that it's not, there's no easy solution to it, but being somebody who was in that situation, I just feel that if there was maybe more transparency or consistency or some data to back up some of these decisions made regarding monitoring and the length of contracts and stuff like that, if there was more consistency, that in itself would help alleviate a lot of that problem. But it's not, we just don't see it.
So I don't know how we'd get that data, and if it ever came out, it would be from the US, where the monitoring is completely different than what we have here, because most of the monitoring for physicians in the US is done by the physicians' health programs. So where I see people who, and I've seen lots of them, I've got these reports, they're almost like they're usually a second opinion, if I'm being honest. And so the person who's made this decision about, oh, and Dr. Manak has a conflict of interest because she does IMEs and then does the monitoring. My answer is, then you do the monitoring. Do the monitoring, because unless you're going to offer a service, instead of just complaining about it, it doesn't do any good to complain about it. Offer the service, and then there'll be more services for people to choose from. But the problem is there's a paucity of services outside of like East of Hope. And so pre-COVID, when we weren't doing telehealth, it was the patient's choice whether they wanted to drive to Vancouver initially once a week and then once a 2 weeks and 3 weeks or whatever. But the answer, the blame cannot be put on people who are trying to provide a good service to patients who are already marginalized and discriminated and can't find treatment and can't find help locally. And I get there's lots of physicians that don't think this way. And I hope, Nathan, you know me by now that I'm not one of those.
I know who you are.
I know you know who I am. But in the same way that, if we're saying pharmacists can prescribe, and they have a vested interest in the pharmacy that's going to be profiting from this, should we paint every pharmacist with the same paintbrush? Because there's some pharmacists that don't have those boundaries, and what those limits are maybe need to be set like higher up. And I don't know who would do that or how they would do that, but I don't necessarily think it should be blamed on the pharmacist that's trying to provide a service to that patient in front of them at the time in the best way they know how.
Yeah, I think a lot of it has to do with what's on the line, right?
Yep.
A difference between a 3-year contract and a 5-year contract is a lot, especially for pharmacists, dentists, any other poor profession that has to pay for it themselves.
And physicians too. Yeah, they're in there.
It's not just the financial aspect. It's you're looking down the barrel of this, big change in lifestyle for a long time type of thing. It's quite an undertaking and I think it's easy for people to look at what they've received and then react to it, whether there was any financial incentive involved or not. So It's another area where you're exposed. And my solution to that would be, well, why don't your fees should be upped substantially, first of all. And then maybe there should be some barriers put between MROs and that industry.
Right. Or like we send out all our chain of custody urine samples, but that is another big contention because that's a moneymaker right there. And so if you're doing the caduceus group and you're doing the IMIs and you're doing the monitoring and you're doing the lab, I mean, clearly this is referring to yourself many, many times over. But maybe the answer is that we need a Canadian regulations, guidelines. I don't know who would do that. But there is the, the occupational and environmental something or other, which I'm also a member of, just so you know. but we don't have robust guidelines in Canada. So maybe we need to come up with some.
Well, that would be a start.
But maybe we should treat addiction patients like all our other patients, that when they need treatment, it's available on demand at not an additional exorbitant cost, and maybe those costs should be covered. And then maybe we can have like a lab that might do the kind of monitoring stuff that's set up by, I don't know, Ministry of Health. I don't know what the answers are, but until other people are going to be offering monitoring services, then I think, it's easy to complain about people, but much harder to come up with a solution. And so I'm trying to offer a service to a patient who then doesn't have to drive to Vancouver once a week.
Yeah.
And if that doesn't work for people, then I give them the option to go somewhere else. It might not be a great option.
No, it's a terrible option.
But it's a then it's a choice, because literally outside of Vancouver, there's 3 people doing this.
Yeah.
So,
Yeah, that tells you something right there, right? Like, I mean, for such a, I mean, this is you're in a position that requires you're giving a lot, not just professionally, but you're in a situation where you're seeing people who are in a bad spot all the time. And if you're like me, or Corey or many healthcare professionals, you want to help people, not contribute to them being in a bind.
Yeah.
So this is an energy that's being drawn from you. And if it's going to be drawn, then there should be a payment that's equal to that. And I don't see that right now.
I don't see that right now either.
Yeah. So,
and monitoring is not also for the faint of heart. I don't like reporting my colleagues to their college. I don't like reporting nurses. And it always seems to happen on a Friday afternoon at 4 o'clock when somebody has given me a positive opiate screen, and now I got to find people at their college or phone the patient or whatever. It's not really for the faint of heart. But as I've said before, I would close up ICDO if I ethically felt that I could abandon my patients. But to be honest, by closing up my monitoring, side of things, I would feel like I'm abandoning my patients. And that doesn't leave me, it leaves me as I'm damned if I do and damned if I don't, which is worse for my moral injury in terms of what I'm offering. I feel that I offer an ethical practice. I know that maybe not all practices think or feel this way, and that's maybe not what they're delivering. But at the end of the day, I mean, I have to work within the system that I'm in. And to be honest, I wouldn't do it any other way. Unless there's some major systemic changes, because then that means my patients will have to go to maybe somewhere where I think, I don't want to get into that, but they'll have to go somewhere else, or they'll have to go to the coast.
Yeah, well, maybe the have to thing is something that should be looked at closely too, but I know what you're saying anyway.
Yeah, but I wanted to bring this up because I'm a pretty black and white person. I don't like pussyfooting around about this. This has been in the air for a long time, so I'm glad that we finally got a chance to clear some of the air, but realize that I don't know what the answers are.
No, and I don't think any of us do. It's just the first thing when you're dealing with a complex problem you have to do is try to sort out what the fuck is going on.
Right.
So, I mean, that's what me and Corey are trying to do here. We're trying to, get honest, genuine perspectives from people who are involved in this thing. Yeah. And then once we've got kind of a baseline to work with, at least some ideas could be presented, right?
Well, what I would recommend is, because I think things may get a little worse, because I know that, with people kind of approaching retirement age, some of the, I don't want to call them us old timers, because we're not, certainly I'm not, but there are some very experienced people that are going to be retiring, and then you're going to be left with people who really are not qualified MROs. They don't even know what an MRO is. And they're not, they might be, board certified somewhere, but I think that dealing with safety sensitive individuals, particularly healthcare professionals, but even mine workers and CN workers, most guys, some guys doing this don't even know what the regulations are, because they've just kind of been, dropped. Hey, will you do an IME? Sure. What's so hard about that? Well, it is a lot of work. Like my reports are like 28, 30 pages long. It's a lot of work. A lot of thought goes into them. That's not always the case. And I don't know moving forward what it's going to be like, because I find in addiction medicine, the health authorities basically just, in the fee-for-service model, the health authorities just want us all replaced with nurse practitioners and, prescribing nurses, and they don't really value the expertise of a board certified addiction medicine person, because we don't really have that in Canada.
Yeah, and I think, to me, it's more, if there was a way of valuing, like, are you required? Is anybody in the position to be a MRO required to do any kind of data, not recovery, just monitoring, tracking data over time? Like, do you look at what's going on with your patients at a 5-year mark or 10-year mark? Do you do anything like that?
I probably don't have a robust enough service to do that.
Yeah, like I would suspect that you don't have the resources to do that, but.
Well, that's the other thing. Should we do that? Absolutely. Have we talked about doing that? Sure. The limitations are, we have an EMR that doesn't really allow for monitoring type of data. It's an EMR that's meant for soap, sore throat, blah, blah, blah. To set that up in our EMR, which is an addiction EMR, it's specifically meant for addiction. It's a challenge. There's only one company I know, it's in Vancouver. They have a true monitoring EMR. It's out of the US, and they have the sole a license to use that in Canada. So, part of this is all these system problems, but I can tell you that, people who are monitoring need to go and become a medical review officer. And that in itself is a barrier to having more monitoring companies. People who, are going to do IMEs for nurses, pharmacists, and physicians should be part of the Federation of State Physicians Health Program, because that's all where our guidelines come from, is from that source. I think that people need to focus on a recovery kind of, oriented system of care for healthcare professionals, rather than more of the harm reduction approach, which is huge in BC. And I'm going to tell you, this issue is much more prevalent, the conflict of interest and, people complaining and, it coming mostly out of, some centers in Vancouver. It's only a problem in BC. It's not as talked about in Ontario, where we have the same challenges, the system problems, i.e. there's a paucity of people providing the service, but at least in Ontario, you have more population to kind of like serve that, more doctors, but it's the same problem in Alberta, where people are spread out. We don't hear this problem in Alberta, but it seems to be, much more talked about in BC for sure. And I don't necessarily know the answer to why that is, but
you're talking about the conflict of interest?
Yeah.
Okay. But you how does that relate to harm reduction?
So I have actually had second opinions on IMEs that I have done, where I said they have to go to a self-help meeting, and somehow that is translated into, we don't like 12 steps. I'm like, read my report. And nowhere in there does it say 12-step. And I know we said recovery starts after that, 28-day to 42-day inpatient treatment, because it starts in the community. Well, what are you going to do in the community? I don't care which self-help meeting you pick. You can pick Smart Recovery, you can pick Dharma, you can pick LifeRing, you can pick 12-step. It doesn't matter to me. Pick one. But there's a lot of people that go, well, it's coerced and it's more dangerous, it's more harmful. And you know what? It's only harmful if you're bucking the system every inch of the way, because this is part of your recovery in the community. It's one of your tribes, right? Like we talk about being part of a community and part of a tribe. That's one of your tribes. There's also, well, they don't need to do urine drug screens. I'm like, really? Well, how am I going to monitor them? Okay, well, then they don't need to go to 12 self-help. They don't need to do urine drug screens. They can go to work on Suboxone. Where's the monitoring in this? Where are you getting the reasons for these decisions? What is the evidence for it, other than the own evidence that you have done your own research on, which is a conflict in itself? So if you're doing the research and go, well, you know what, 12-step meetings are, they're harmful to people when they're coerced. That's your own data. That's your own research. Is it a conflict of interest? Now you're putting that on all these reports and saying people shouldn't have to go to self-help meetings, any self-help meetings? So I think we have to be careful about the qualifications of the people writing these IMEs, the qualifications of people, doing second opinions, and the qualifications of the people doing those reports that are saying there's a conflict of interest in these, monitoring IMEs, because then I'm going to say, great, I will do the IME, you do the monitoring. But unless we're willing to have more people doing monitoring, then it's going to be the same old people doing the monitoring, because they're the ones that have actually gone out of their way to become MRO certified in the US at considerable expense and cost, because they want to provide a service to their patients that is convenient, at least.
Okay.
You're not buying it.
Seems like you might be harboring some resentment towards.
I am.
Yes.
I do.
I'm going to leave that alone. Corey?
I certainly feel more informed and more comfortable with what you've explained to us than before we had the conversation.
Yeah.
And I think none of us really know what the answer is. And I think that is part of the issue. Maybe we need to get all these regulating agencies together, and maybe we need to get all the people doing IMEs and maybe doing the monitoring to sit down in a group and brainstorm about how we're going to treat patients without this inherent conflict of interest that is omnipotent, and figure out what's the best way forward. But to be honest, I don't have the energy or time to do that. So who's going to do that?
Well, fair enough. It's much more about, as I'm understanding it, I think, the analogy that Nathan and I have used of the machine being so, sort of disconnected from each component. And each component can kind of, there are fractures there are disconnects there.
Or shorts, right? Where you get conflicting pathways that run into each other and cause,
when I first saw you guys' recovery machine, in my head, what I had pictured was a meat grinder. And that's really what I feel like. You put everything in the top and you turn things through, and it comes out the other end. That is sometimes how I feel, to be honest.
You might have to add that in somewhere, Corey.
I don't think you would be alone in feeling that.
Right. And so this is why I have some resentments.
Sure.
Oh, well.
You heard it loud and clear, and I have no problem admitting that. I just don't know what to do about this systemic problem on my own.
You have resentments because you care, right? I mean, if you just were, because there are people who are running operations that are kind of more in line with what you would call a machinist or factory methadone, they just fire them out at maximum speed. And
it's called McMedicine.
Yes.
Yeah.
So
I don't practice that way, but whatever.
I recognize that there is a difference there. But
I think maybe we can't rely on individuals to decide what their ethic boundaries are, because there will always be people that cross those boundaries.
Mm-hmm.
Yeah. It's when there's human beings involved in mass, it's the complexity grows exponentially.
Yeah.
How you doing here, Mandy? We are really taking it to you. And
well, I fully expected you to rake me over the coals.
You're doing good.
I never back down from a good, robust discussion, because I think unless we're going to have these discussions, things don't change. Mm-hmm. And unless, we talk about these openly and honestly, I'm never going to know what it's like for somebody to go through a monitoring program unless somebody tells me. Mm-hmm. And you're never going to know what it's like to be on the other end where, the first thing I tell my patients is, I know that you don't want to be here. I know that you don't like me very much right now, and that's okay because I probably wouldn't like this either. If we can't put ourselves in each other's shoes, like then, maybe that's part of the problem is that we don't have that empathy of somebody whose shoes you could be in, right?
Well, yeah, I'd like to think that that's a prereq for anybody in a position in the healthcare system, really anywhere, but it's definitely not.
Definitely.
I think that somehow our society excludes physicians specifically in the
Yeah.
need for empathy and understanding. It's like we need to be empathetic and understanding of everybody except physicians. I see that. I see that
I feel
everywhere.
that. I feel that.
Yeah.
It's kind of like when I said you go to a meeting at a health authority and everybody's getting paid to be there, except you're losing money because you have to take time off from your clinic to go do the health authority work, right?
Yeah. Well, people in this province, especially, I think their attitude, many people's attitude is just one of entitlement. Because of our healthcare system and how lucky we are to have the healthcare system we do, even though the thing has fallen apart, they're used to being able to see a doctor. And they think it's okay to just waste doctors' time or call them, treat them poorly. And I don't know. It's a strange.
I think it's that, yeah, you're right. It's the one of the reasons that there's a little bit more burnout is patient expectations. So, I take my time with my patients. I have very complex patients. They're, alcohol, cannabis, benzos, things that no other doc wants to do because, hey, you know what? Opioid agonist therapy is easy. You just give them a medication and out the door. I know some physicians that barely look up from their prescription pad. I don't work like that. But at the same time, then I'll go out into the waiting room and there's like people like, what's taking you so long? And, they're yelling at my staff. And it's like, you can't win for trying. You're either damned if you do and damned if you don't. And so I don't know what the answer to that is either, but you can only practice the way that you can look yourself in the mirror every day and go, I know for sure I'm not harming because that's my first job in medicine, but I'm doing the best that I can with what I have at the time. And I think I am being more useful than not. Because that's the only thing we can do in medicine these days sometimes. You can't even say you're doing a good job anymore because you don't feel like that very often. I mean, not unless you're working in a, non-fee-for-service model somewhere that, you get the luxury of working with allied health and, physio and pharmacy and nurses that doesn't really exist in BC, right?
Indeed. Yeah. You got it in you for one more question or?
Yeah, sure.
Okay.
So we wanted to ask you about the idea that treatment does not have to be voluntary to be effective. It is often perceived on the receiving end of the IME and of the sort of the decision or the diagnoses that you're going off to inpatient treatment or you're going to complete an outpatient treatment, and it feels involuntary. And sometimes there's maybe a spectrum of resistance or of a rub there. Maybe not.
Not sometimes, often. Yeah.
Often. So does it have to be voluntary to be effective? And what are some of the factors that guide your decision there? Because that must be a very challenging decision to have to make.
So let me just step back a little bit and say, the disease of addiction means that a substance that has given you more dopamine than the rest of life has hijacked your reward pathway. And that means that your frontal cortex, which is responsible for those higher functions and judgment and insight, has really taken a backseat to the amygdala, which is the here and now, the instant gratification, the memory, the pain, the addiction, all those things, right? So the illness itself lends to minimization, denial, and perhaps not understanding how you're possibly going to live without this substance forever, because that's what got you through till now, and that your life is somehow going to be so boring unless you can drink every day or use an opiate every day, because there are some very characteristic effects that each chemical has on your pattern of thinking. So for example, the guy who drinks too much is like, you know what, I don't have a problem with my alcohol. If you have a problem, that's your problem, but I don't have a problem with my alcohol. You don't like it, then that's your problem. So there's a lot of minimizing, there's a lot of deflection. Like if you had a wife like I did, you'd drink too, right? So you're blaming the wife when you're drinking. Not that that is necessarily wrong or incorrect, because it might be true for that guy, but the bottom line is he's minimizing because the insight and judgment has been impaired by this chemical called alcohol. And so the alcohol use patients don't think they need help because their illness isn't really that bad. Nobody thinks their illness is that bad, and they don't really want help because it's everybody else's problem. The guy using opiates knows he has a problem. The problem is he does not know how he's going to stop using an opiate because he feels good when he's using it, and he thinks his life is going to be like shit when he stops using, because he doesn't know how he's going to stop because he's tried that many times. So they know they need help, they just don't want help because they feel better when they're using. So there's this pattern, this cognitive kind of pattern that happens, that it's not that they're reluctant towards treatment. They know they need treatment. They just don't know how life is going to work out after they stop using. With cannabis, it's like anything you're doing is really good. It's like, hey man, it's like all good because I'm happy doing nothing. So each chemical has a distinct pattern of effect on cognition. When they come see me and I go, yep, you have an alcohol use disorder, and he's already of the mindset, because he's lost insight, lost judgment, because his reward pathway has been hijacked by alcohol, to kind of go, yeah, no, that's not me. I don't need that. And the opiate guy is saying, well, I want treatment. I know I need help, but I don't think I can do it. So I'm not going to do it. Whether they go to treatment or not is not necessarily up to me. It's called contingency management. And so in a monitoring setting, the contingency is, you want to keep your job, then you should do this, because otherwise you're not, you're putting the public at risk. So ultimately, it's a involuntary voluntary program, which isn't much of a choice. But you might be surprised at how many people go, you know what? I'm so glad I did that, because my life is so much better. I did not know how I was ever going to, stop using alcohol, because my life was going to be boring. And I think it doesn't need to be voluntary to be effective, because we see it, like I see it anyways, in my practice all the time, where people that have lost that insight and judgment and maybe don't think their illness is bad enough, don't want to go to treatment. But once they do, and they're, in stable, sustained recovery, their life is just so much better, and they don't know why they didn't do it sooner. But there are a lot of people that never get over that resentment of, I don't want to do this, you made me do this. And so, if you had a wife like mine, you'd drink too. Or if you had a monitor like mine, who's, a schmuck or an asshole or whatever, you wouldn't be doing well either. So I see people do well all the time, whether it's voluntary or involuntary. And at the end of the day, if the reward system has been that hijacked that they can't see the need for treatment, it's kind of like saying, I have cancer, and eventually it's going to be terminal. Do you want treatment, or do you don't want treatment? And the cancer patient goes, yeah, you know what? I don't think I'm that bad. I don't think I want treatment. And so you would look at that person completely different, go, what's wrong with that guy? Doesn't he know he needs, an excised, or he needs chemo or whatever? And so we think of, and ultimately it's still about an informed decision, but at least in the cancer guy, his cognition, insight, and judgment are not impaired. And we know that addiction is an illness where all those are impaired. And so we treat people differently. Like for example, we can involuntarily, commit somebody who's got depression and suicidal.
Yeah, you could section 5 them. Yep.
But we don't do that with somebody who's overdosed 8 times in one day and who's going to go out and overdose again because it's addiction. There's no psychiatrist that will do that. And I'm not saying we should do that, but what I'm saying is we treat addiction medicine differently because it's addiction.
Let me ask you this. Do you think that it's possible that some of the patients who come in to see you, the ones who have been reported or whatever, caught, do you think it's possible that when they come in, they do actually have sufficient insight? Their problem is not that bad. Yes, they got caught doing something, but they're actually quite aware of what's going on. And as far as, their own autonomy is concerned, they are not in a category such that they would require like a section 5.
Oh,
and
talking section 5 in an outpatient? Sorry.
I'm just using it as a way to say this person they may have been reported for drug use or whatever.
Oh, I see.
They show up in your office. How do you know, like, how can you be sure that that person has insight or not?
Oh,
it just sounds.
often it's obvious, to be honest, but there are a lot of people with intact insight and judgment. But here's the thing. So, we go by the DSM-5. We'll go like, what kind of consequences have you had? I'm going on the assumption that if they could have stopped on their own, they would not be in the position where they're at, and they wouldn't be sitting in front of me because they wouldn't need me. They would have done it on their own, not because they didn't have insight or, not enough, but because they were able to manage all those other things, whether it's stressors or cravings or withdrawal or something, that they would not need this assessment. Even when they ask for help, they've often tried to do it on their own many times and haven't been able to. So if they're sitting in front of me and they are meeting, like, I don't know, 6 out of the 11 criteria under DSM-5, it tells me that their illness is bad and advanced enough that maybe outpatient treatment is not going to work. Maybe, just self-help meetings or PTSD treatment is not going to work. That their illness is advanced enough that now they're sitting in front of me and they need more intensive treatment. Because I'm going to tell you, people don't get to be sitting in front of me by accident.
Well, actually, they do, right? I'll give you a couple. I've got clients who, guy likes to smoke weed and drink some beers on the weekend. He's a nurse. His girlfriend gets mad at him and reports him to the hospital. Okay?
Not a nice girlfriend.
No. He ends up getting sent for, even though he was drinking at home, not on shift. She tells him that he was drinking so much last night that he's probably drunk at work. Whether that's true or not, we don't know.
Right.
Now, this guy shows up in your office and he didn't ask to be there, right? It's because many healthcare workers are like, I've seen people who are doing 3-year contracts for Tylenol 3s. And the reason they were taking Tylenol 3s was because they had an undiagnosed severe spinal problem. And once they got that figured out, it's just that really what was happening is they're working so hard, so, because they were worried about their new practice, that they never got assessed and they just started taking T3s. And then they ended up in a situation where they had to be in a contract for 3 years. Like, could you see where sometimes?
So I haven't had any of those examples, and I don't want to comment on cases that I don't know details on. Do I think people,
like, some people like doing drugs, and that's what's wrong with that. Some people can drink wine when they're out with friends. No big deal.
Yeah.
Everything's managed.
So without knowing why that girlfriend, which I think this sounds a little, there's some dysfunction there for sure. I can't really comment because I don't know the details. I'm assuming that whoever the assessor was doing the IME did, all of the, robust assessment that was necessary. And can we still be wrong? Sure. Could we be right? Maybe. I don't know the details of that case, so I don't really feel well qualified to answer on those specific things, on those two specific cases. But it's kind of like the rest of medicine. Can we come up with a wrong diagnosis? Sure. Could we be wrong? There's no 100% guarantees in medicine. And yes, this means a major life change to somebody, but I don't know how to get around the fact that there's nothing guaranteed in medicine that we can come up with a wrong diagnosis.
Sure. So, like you said before, from your perspective, as long as you're doing more good, which is, I guess, what any physician tries, they start by trying to do no harm, right? And then you're trying to, every intervention is usually a risk versus benefit. I just wondered how, because there's so much difference between people when it comes to this particular behavior.
Yep.
Yeah,
Yeah. So, I'm assuming that the person doing the IME, did obviously biological testing. And, if somebody doesn't have a problem with, say, cannabis or alcohol, they probably wouldn't be positive at the time they showed up for the IME, because I know, like somebody said, you're going to lose your job if you're like smoking that much pot. I'd want to show up with a negative urine drug screen for sure. Number two, they're always supposed to get collateral information. So you should be phoning employers. You should be phoning this girlfriend as to why she felt so compelled. So when I do my IMEs, I usually get 3 collateral information that the person themselves has recommended. And my question is, in your opinion, does this person need help with any sort of substance use disorder? And then they can tell me why not or why. So I without knowing what that IME consisted of, it would be really hard for me to tell. But to be honest, I think, it's kind of like having a surgeon that says, you can have your appendix out because we think you have appendicitis, and then take it out and there's nothing wrong. Could we be wrong? Absolutely. Is it more dangerous to leave the appendix that you thought might rupture in? Absolutely. Which one is worse? Depends on the situation.
Yep.
I mean, that's not an ideal answer, but I guess the bottom line is, do we make incorrect diagnoses in medicine? And the answer is yes.
Yeah. Yeah. No, go ahead, Corey.
I was going to ask, how do you ensure privacy in obtaining collateral?
So when we usually ask for one supervisor at work, or somebody who works daily with that person, if it's not a supervisor. So, I'm talking like we have people, like we do all the contracts here for Afton Mines. So, it's people who have a direct supervisor. There's a mine supervisor. In a hospital, it's a little bit more different, but I usually say, you're going to talk to these people. You're going to give them a heads up that I'm calling. You're going to tell them why. And what I'm looking for is, and when people first show up, I say, my job is to get your story and put it on paper. And then when I ask for collateral, I say, their job is to corroborate your story. Are you late for work? Are you missing a lot of, days at work? Or is your performance changed? All these things. So I to say, you need to contact these people. We want one supervisor, ideally one colleague, and then any other personal, you could be your mom, dad, sister, wife, whatever. But usually we want to know if it's impacting work. So those are the more relevant ones, right?
Yeah,
so
interesting.
In terms of privacy, it's up to the patient to give me a name and then talk to that person that they feel comfortable with. I realize that it's not always comfortable to tell your supervisor at work that, Dr. Manak is going to be calling and she's going to be asking me about if I took some hydromorphone from the PAC system. That's not a comfortable conversation.
Sure.
Yeah.
That wasn't asked of me. I wasn't asked for any collateral information, and nor was there ever any evidence apart from the Pyxis machine and my documentation. But there was no coworkers reported me. No coworkers were aware of my.
Oh, no, I'm not talking about coworkers being aware. I'm talking about where I'm going to phone somebody for collateral information that you have told me their name. That's what I'm talking about. And
I see.
That would go in the report. So Nathan, I don't know when you read these reports, but if somebody gets some collateral information, it's usually written in there. And this is what I mean about these standards, that if you are doing a good IME, anybody should know that they need collateral information, because it's one thing to take, the patient's, not to say that people lie, but I want to corroborate your story. I want to know if you're late for work every day. I want to know if you're used to be 5 out of 7 attendance and now you're 1 out of 7, and you phone at 4 a.m. sounding intoxicated because you're not going to show up that morning. That happens all the time. So people who are doing these IMEs need to really know what the standards are. Right?
Yeah.
Well, that makes sense.
Yeah.
You have given us much to consider, Mandy. And
because you knew I would.
Well,
you know I don't hold back, Nathan.
I'm grateful for you taking the time, and especially with how candid you've been with us here. It's I think a lot of people are going to get value out of hearing somebody speak like that, especially somebody in your position. So
I think if we can't be candid with each other, then we probably shouldn't be having this conversation anyways, because there's no point in pussyfooting around. Things are, for the most part, kind of black and white, and the grays are too gray sometimes, and we need to kind of get out of that.
Yeah.
Yeah.
Well, I think we're going to leave it there. That's it's quite impressive. You stood up to some intense questioning there.
Grueling. I'm going to say it was grueling.
It's so interesting to get your perspective, and really thanks for doing this. I know you didn't have to, and I also know how busy you are. So it's very appreciated, and hopefully it's going to open some eyes and bring more awareness to the table.
For sure.
Yeah.
And it's a much broader conversation than I expected to have. So I'm appreciative of that. And I know that our podcast has become a broader conversation. And so to bring you into that and to have our specific conversation be like that is really cool.
Absolutely.
One of the things I feel compelled to say is, and this is not just in my monitoring practice, but it's in, my regular practice as well, is I think patients with substance use disorder are some of the nicest people you will ever meet, but sometimes they've got this internal stuff, maybe because they're too nice and they'll give you the shirt off of their back. And maybe that's kind of the, part of the issue for them, is that, they're really just people who are hurting inside sometimes, and we have to remember that. In the same way that somebody breaks their leg, we can see that, but when somebody's got a substance use disorder, it's the pain inside that we often don't see. But really, they're just and I'm not just saying this because you guys are in recovery, but really, I think they're just some of the nicest guys you'd ever meet, and they'd give you the shirt off of their back.
Yeah, I think that on a weekly basis. I totally agree with you.
Yeah.
All right, Mandy, we're going to let you go. Have a good evening, and I'm sure we'll talk again soon.
All right.
Thanks.
All right.
Great
Thanks,
talking
guys.
to you.
Thanks, and see you soon.
Okay.
You too.
Bye. Bye.